Thanks, PK. It's great to be back in person. So I'm going to try to preface things before the case with what we know and what we don't know about alternative access. So things have evolved, and now we have a myriad of access choices. And if you're in the structural heart world, you have to include transcarotid access now. That's been proven to be safe for some structural heart cases. So we have all of these choices. So now, what kind of equipment do we have? And we'll get to that later. So in spite of this myriad of choices, people tend to go femoral no matter what. So it's still, you see a radial rate of less than 1% and femoral access of one variety or another 2/3 of the time. And so why do we want to go radial? There's a lot of reasons. Reduction in bleeding complications would be one. Patient satisfaction, meaning, going home in a couple hours versus laying flat for 4 to 6. You can ambulate, you don't have any leg restrictions. And then reduced length of stay, I would say, the goal is same day discharge. So, and we've all seen these sorts of people, and I'm from Oklahoma City, so I may see more of this than most everyone else, but the body habitus thing is a real deal. And then there's difficult anatomy. So people have had all sorts of prior revascularizations or tough arches or densely calcified, nearly occluded vessels. And so in these cases, you have to pick some other way to actually get the case accomplished. So there's not a lot of data, as PK said, but this was one article that kind of compared, it was about 70 patients total. And interestingly enough, things were pretty much dead even in terms of complication rates. Now, if you read the article, they reversed this in the table. So the transradial access site complication rate was 2.5 and the other 6. But when you really read the article, it wasn't even access site complications. Actually, nobody had a complication at the access site. They were classifying a complication in the case. So I don't know why they did that, but anyways, I just wanted to point that out. So case planning. I mean, first of all, you need to know the size of your radial artery. So we'll get to, the use of ultrasound. You need to know the level and location of disease. And that's why I've been such a heavy proponent of CT, because CT can give you a lot of information ahead of time and help you plan. And then when you start to talk about what's available, you need to sort of know things about the patient, because if you have a very tall patient, then maybe even a 120 or 150 sheath isn't going to be long enough. If you've got a very short patient, sometimes you can take a 90 centimeter and get into the origin of the common iliac. And then you have to decide your access site. And then a lot of people are just used to going right radial because that's how we do coronaries, but you'll find that left radial sometimes is a better choice. It gives you a little bit extra length and it's a little more straightforward. And then I think when you do these sorts of cases, you need to prep multiple areas. I don't think you decide to do a radial case and then you just exclusively, stick to radial. So in terms of, best practices, obviously you want to assess the radial artery for patency and size, because that's going to help you decide on sheath diameter and what the maximum sheath size is going to be that you're going to be able to get away with. And then when you're putting in these sheaths, so the biggest difference between doing a peripheral radial case and a coronary radial case is obviously the length of the sheath. And so things like wetting the sheath as you're putting it in, and then when you're taking the sheath out, putting the dilator back in a stiff wire like a supercore helps, because you're invariably going to have some sort of spasm, and it's not going to respond to nitrates and that sort of thing. I've tried everything, nitro paste on the arm. When you get stuck with a long radial sheath, you basically have to sedate the patient. That's the only thing that's going to deactivate their spasm, is just being knocked out. So there are some nuances. It's not just like doing a coronary case. And so there's not a lot of equipment, but now there are dedicated tools. Okay, so there's long sheaths that are 6 French. There's really long glide wires and really long glide caths. And then there are balloons and stents that are made for this sort of long sheath, because as we'll point out, this is where the limitation is, because it doesn't really matter how long your sheath is, and it doesn't really matter how long your wire is if you aren't able to get the definitive therapy that you want to the spot. And unfortunately, at this point, it's plain balloons and bare metal stents. And so I don't know how many of us are really satisfied with that as our solution. So I think that's still the gap. So here's a 200 centimeter shaft bare metal stent. And I mean, it's great if you're going to treat with a bare metal stent, but if you're wanting to use a woven nitinol product or you're wanting to use a DCB or a DES, it's not going to work. So we're moving in the right direction, but we're not quite there. And so this is kind of a case that I had looked at with CT first, and then decided to get left femoral access, and then I was just going to see how much or how little I was going to be able to get accomplished. And so when you look at all the different lesions, there's iliac lesions, there's common femoral, especially on the right side, that's not adequate for any sort of access. In-stent restenosis, aortoiliac disease. And so these are the sort of things that have to go through your mind. Like, how are you going to approach this? What are going to be your access choices? And there's multiple, and you could even do a mix of tibial and femoral if you wanted to, but you got to somehow be able to visualize and accomplish the case, and it's probably not going to happen via one access site. So this is all the stuff that I did that I could do from the left femoral. So I went ahead and took care of the right common femoral, did a DCB that extended across the iliac disease, did a DCB of the left-sided ISR, and then here we are. So I'm almost done, but I've just worked on the right common femoral, so I don't think that, or I'm not a big fan, and maybe some people on the panel can correct me, but I mean, I've just ballooned this common femoral, so I don't really want to stick it for access. So in this particular case, I found it very useful to then go through the left radial. And you have the left radial and the left femoral. You know, you can use the left femoral for your visualization and for protection, and then you can deploy the stent via left radial. Now, this was a tall person, so you know my radial access was great. My 90-centimeter sheath was not, and so so there's a long gap between sheath and when you put the stent in, but you know, over an 035 wire, you're pretty safe in terms of anything bad happening. And then, of course, I had the left femoral site for visualization. And then, you know, obviously it reduces the chances of femoral complication if you don't stick both femorals. And then of course, you also had left femoral access there for a bailout. So let's just say something happens and you perf, the left femoral site's at least adequate enough to upsize and then put up a balloon and try to save yourself a little bit. So pros and cons, I would say radial access is safe and effective. It helps you with same-day discharge, which increases your patient satisfaction. And I think it's largely possible for iliac and femoral disease. I think once you start getting down into the SFA popliteal, you're limited more by the choices in terms of balloons and stents than you are by sheaths and wires. I think the sheaths and wires have been taken care of. There's even a wide array of 4 French products that I think are great. It's just that nothing that we want to really use either is long enough or goes through 4 French. So we're still stuck kind of where we were, in that the cons are still there, right? You can't use some of the stuff you want to use because of the lack of length. And then the sheath insertion removal, again, I would just reiterate that it's not like pulling a sheath after a coronary case and putting a radial band on. I mean, some of this, at some point during the 100 centimeters of pulling back, you're going to run into some spasm on a lot of people, and you just need to be prepared to deal with that. And then, you know, you have to be willing to change. So nothing stays the same. Thanks.